This program is brought to you by Emory University.
Good morning, everyone, and thank you for joining. Today, it is my pleasure to introduce colleague and a friend, Dr. Maria Carolina Gongora, who went to medical school in Bogota, Colombia, and then lived in New York for a few months before moving to Atlanta to work as a postdoc in Dr. Harrison's lab and focused on mechanisms related to hypertension. She worked on endothelial dysfunction as well as renal medulla and the role of this in hypertension. She subsequently completed internal medicine fellowship at Emory, internal medicine and cardiology fellowship at Emory, and within part of her cardiology fellowship also spent 2 years in Harrison lab. So I think if I counted right, Maria, you did 4 years of research in the area. Maria has been very active at the American College of Cardiology Hypertension Working Group. She has received several awards in this area, especially the American Heart Association Women in Cardiology Trainee Excellence Award. She's very active in our Emory Women's Heart Center and frequently invited to present on this topic of hypertension, and has more recently been focusing on cardio-obstetrics and working with Dr. Cutchins there at Midtown. She answers all of my hypertension and pregnancy questions and sees those patients. And I was joking with Dr. Gongora earlier that she couldn't refuse my invitation since she's my next door neighbor. So I appreciate you being willing to present today, and I'll turn it over to you.
Well, thank you, Pooja, and thank you for the invitation to talk. So today I want to talk to, so Pooja asked me to talk about guidelines, hypertension guidelines, and there has been a lot of controversy, but today I'm going to included a big part of history, because I'm sure some of us and some of you haven't had a chance to look into interesting things of where these guidelines come from. So first, I know to this audience is too much to say, well, hypertension is relevant, but I just want to refresh some of the most recent statistics. And hypertension is still the most prevalent of all non-communicable diseases, and prevents more cardiovascular events than the management of any other modifiable risk factors. And there have been several initiatives to control and to reduce the prevalence of hypertension and the adverse impact on the cardiovascular mortality and morbidity. However, unfortunately, the awareness is not still where it needs to be, and the control of hypertension is actually coming down. For the NHAIS survey in 2012, the prevalence was calculated at 30%, and the awareness was 77%. But the control rate, and it used to be, the awareness used to be 30 years ago, it used to be 50%. But the control rate is still 43%, and it's even lower in women. And what is more concerning is that it used to be in 2012, it used to be up, the control rate it went up to 47, almost 50%, and actually came down in the most recent survey. So that's one of the reasons of why we need to focus on hypertension control strategies. Why is the decline in hypertension control? And as we know, in 2017, the new guidelines redefined they modified the classification of hypertension, and of course, it drops to 19% just based on that. However, that doesn't account for the decline, the control in the most recent years. And this 19% change, of course, has been comparable across the races and ethnicity groups, and already taking into account the care inequalities. So what are the potential explanations where we are doing poorly in blood pressure control? Unfortunately, the social inequalities have broadened. So the wealthy groups increased their wealth by 30%. The middle income families decreased their wealth by 20%, and the lower income families decreased their income by 40%. So these social inequalities, socioeconomic inequalities, are actually, instead of getting narrower, they're getting wider. And the health quality for diagnosis and treatment have declined. There are more adults right now taking monotherapy than before, which, as we know, monotherapy is not the appropriate way to manage hypertension. Of course, there is the epidemic of raising diabetes and obesity. And this is pertinent to us and specifically to us in Atlanta, Georgia, because the numbers in southern states and urban centers are higher. And in those states where medical expansion was not approved, which is Georgia, and it is known that those states where medical expansion was approved, there are better controls of high blood pressure. Also, the new guidelines were debated, and the implementation has been inconsistent. And unfortunately, there is failure from the providers to initiate or intensify therapies during the follow-up visits. But then I wanted to talk to you, and this is the first part of my talk, about the history of hypertension and its treatment. Where did it come from? Where did the term hypertension, the classification, and the treatments, the guidelines came from? So this is interesting, and I hope you're going to find this interesting as I did. So where does the term hypertension come from? And it was initially mentioned by the ancient Chinese and the Indian Ayurvedic medicine, in which they felt the pulse of individual, and they recharacterized as heart pulse, what we call currently hypertension. And in the 19th century, Frederick Akbar Mahoman, he was an Irish Indian physician, described what we later knew as, what we now know as essential hypertension, and he could separate it from similar vascular changes seen in glomerulonephritis. In 1877, he gave the first description of, and I found this interesting, that's why I entered this quote on my slide, apparently healthy individuals with raised blood pressure. That was known later as essential hypertension. And as you see here, I'm not going to read all these paragraphs, that this abnormally high blood pressure, high pressure does not necessarily mean disease, but only a tendency towards disease. So since that time, there was a mention of high blood pressure being a risk factor. And here, good living and alcoholic beverages and inappropriately or badly cooked food tend to intensify the existing condition. So we can wonder if that means alcohol use, salty meals, fried food, and what we know now. But that's how initially it was hypertension described. So Frederick Akbar Mahoman, as I said, he was this Irish Indian physician. He actually made the sphygmograph quantitative and portable, and that was published in 1872. The sphygmograph had already been developed by a French and a German scientist, physicist, 20 years later. And he started describing how there was an association between hypertension and postmortem changes on cadavers when they did the autopsies. And initially it was called Bright disease without albuminuria. And later the name was changed to high blood pressure diathesis. So this is how the term hypertension came up. What about the measurement of blood pressure? And I know most of the audience knows about this, but I thought it was interesting to reminder. So as a reminder, in the early 1900s, a mercury sphygmomanometer came up. In 1905, later, and I have a picture of Nikolai Khodorkovsky, he was a Russian vascular surgeon who invented the auscultatory technique for blood pressure measurement. And he described the appearance and the disappearance of the sounds in the arteries, and that was known as a Khodorkovsky sound, so we know now, and that's how they describe the difference between systolic and diastolic blood pressure. Later, at the end of the 20th century, these sphygmomanometers were replaced because of the concerns of the mercury, of the safety of mercury, they were replaced by the aneroid and the electronic devices. So only until 1950 was when we started to measure, when blood pressure was routinely measured in hospital and clinics. And later, the Framingham study showed consistently that high blood pressure was associated to stroke, heart attack, MI, heart failure, and premature death. And however, at that time, believe it or not, in 1950, treating hypertension was still debated. They thought that initially was maybe an as normal aging process. And as you see, it's interesting how it took years before we acknowledged that high blood pressure needed to be treated to the current targets in all across the age groups. So in 1958, in JAMA, that was the first article that came up, and I have a picture here of this article published in JAMA in July 1959. The thiazides was described how the thiazides were well tolerated and were effectively lowering blood pressure. And that's when the thiazides were introduced as the first treatment of hypertension. Later in 1960s, medications with significant side effects, as you can see, methyl-dopa, clonidine, MAO inhibitors, vasodilators like adralazine, and potent sympathetic blockers were introduced as well. And a little bit more of history, and I have included just this table for you as a reference how the different agents were added across the years. And of course, we cannot talk about history of hypertension without mentioning Dr. Arthur Guyton, who developed in 1961 the theory of pressure natriuresis. And in 1967, and these studies in 1967 and 1970, the studies performed by the Veterans Administration comparative studies were very important in demonstrating that those were the first ones that demonstrated that hypertension of treatment of hypertension reduces stroke and heart failure. The agents, believe it or not, that they used at that time were reserpine, chlorothiazide, hydralazine, and guanethidine. And later, this was the first studies that came up showing we need to treat hypertension and these medications work. And then after that, all these several trials, which I'm going to mention some of them, came up. And between 1960s and 1980s is when the pharmaceutical industry just starts actively searching for more effective and better tolerated agents. And I'm going to talk to you about a few clinical trials that I think is important to know as a history of hypertension. And in 1991, only in 1991 is when this study, the SHEP study, told us we need to treat high blood pressure in the elderly, because before elderly didn't used to receive treatment for hypertension. So for the first time in the elderly, it was shown that there was a benefit of treating hypertension above 160. At that time, that was believed to be the cutoff to start treatment, and it was used chlorthalidone and atenolol. Later in 1997, which is a study that we still is still in practice, is the DASH study that showed that the diet rich in fruits, vegetables, and low-fat dairy products substantially reduced blood pressure in adults. Then in 1998, the UK PDS study showed that a tighter control, what they mean tight is by less than 150, and you can see how gradually the targets go down, benefited more diabetics than non-diabetics. And in 2002, the ACE inhibitors showed that the study showed that ACE inhibitors offer more renal protection compared to calcium channel blockers. Then we have the most recent, and we are well more aware of these studies, and there are several trials, but these are probably the ones that we hear more and are more relevant. And in 2002, the ALHA trial, and I'm going to go over each one of them, showed that diuretics were not inferior. In 2008, the ACCOMPLISH trial that was performed to compare the combination of ACE inhibitor plus calcium channel blocker versus ACE inhibitor and thiazides. Then followed by the 2010 study in ACCORD. ACCORD study is a huge study, but I'm going to talk, of course, about the blood pressure section. And then the more controversial study came up right after ACCORD, 5 years later, the SPRINT study, in which more target, as you can see here, how we decrease the targets from now is more strict goal of 120 compared to the non-so-strict 140. However, and I'm going to talk a little bit about these trials, most trials have failed to show significant differences in cardiovascular outcomes with the different drug regimens, as long as equivalent decreases in blood pressures are achieved. So this is the AHA trial that was published, as I mentioned, in 2002. It was sponsored by the Institute of Heart, Lung, Blood Institute, the National Institute. And what it is a huge trial, and it included 33,000 patients, and they followed for almost 5 years. Almost half of them were females, older than 55-year-old patients. And it was a randomized, double-blind, multi-center clinical trial in which amlodipine, lisinopril, or doxazosine were compared to the diuretic chlorthalidone. Remember, at that time, diuretics were also the first-line therapy. And they achieved, they target a goal of, they treated these patients when they had a blood pressure of higher than 140/90, and patients with a known risk factor, either diabetes, MI, LVH, tobacco use, or low HDL. And what it showed, the conclusions was the chlorthalidone, which is the diuretic used in that arm, in that trial, was found to be superior to doxazosine. So this arm was finished. And there was no difference between the groups on primary outcomes, and there was no difference on all-cause mortality. And the 5-year systolic control, the 5-year systolic blood pressure control was actually lower, was better with chlorthalidone compared to lisinopril or amlodipine. Amlodipine compared to chlorthalidone had higher incidence of heart failure, and lisinopril compared to chlorthalidone had higher combined cardiovascular disease. At that time, the conclusion of this alpha trial was that fast-side diuretics, specifically the chlorthalidone, was superior in preventing one or more major forms of cardiovascular disease, and it was less expensive. So they remain on the list as a first-line therapy for treatment of hypertension. Then the accomplished trial came a few years later that was funded by Novartis, in which the accomplished trial was a little bit smaller trial, but it's still pretty large. 11,000 patients followed for 3 years, an older population, older than 65 years old, 40% were female. And it was also a randomized double-blind multi-center clinical trial in which it was compared benazepril with amlodipine compared to benazepril with hydrochlorothiazide. And this is important because this is part of the criticism of this study. And they included patients with a blood pressure more than 140/90 that had a history of one of these events. The primary outcome actually was lower in the group of benazepril amlodipine combination versus the benazepril hydrochlorothiazide group, and this is statistically significant. However, the blood pressure control was achieved by both combinations. And the group of benazepril and amlodipine resulted in a highly significant reduction of risk. So the conclusions of this study was that the benazepril amlodipine combination was superior to the benazepril hydrochlorothiazide combination in reducing cardiovascular events. However, this trial had significant criticism because they noticed that the 24-hour blood pressure control with the hydrochlorothiazide was not as good as the amlodipine. And one of the criticisms at that time and concerns was that chlorthalidone should have used instead versus hydrochlorothiazide, since the hydrochlorothiazide didn't achieve blood pressure control at the 24-hour period. And also hypokalemia wasn't strictly controlled at that time. So there was this question mark about how legitimate these results were because of that. Then the ACCORD trial, as I mentioned, it was published in 2010, sponsored by the National Heart, Lung and Blood Institute. It included specifically in diabetes patients, type 2 diabetes patients, and I'm going to mention only the blood pressure arm. And the design was 4,700 patients with type 2 diabetes, older than 4 years old, with no cardiovascular disease. These patients were pretty high risk, and most of them were uncontrolled diabetics. And they randomized them to either intensive therapy to achieve a blood pressure less than 120 versus less than 140. And they followed these patients for a year. It was an open, in this case, this trial was an open label administration of all antihypertensive agents. So we're not comparing here to specific drug classes, but the target control, the targets. And what it was found is that surprisingly that there was no difference between groups in the primary outcome or death from any cause. However, the annual rate of stroke was lower in the intensive control group. Of course, as expected in the higher rate, there was a high rate of side effects in the intensive control group. And there was significant debate about this study when it was completed, because, of course, everybody was expecting that a tighter control in diabetics was going to provide an advantage in terms of death and cardiovascular outcomes. However, the criticism was that one, these patients were high risk. Two, there were other at that time, other therapies like aspirin and statin were applied to this group. And there was this, and again, one of the rationales to say, well, I don't know how valid this is. We don't know how valid this is and how much of this data will apply in the next set of guidelines was the fact that the stroke was lower in the intensive group. Then came, to add more to the controversy at that time, came the SPRINT trial, which was published in 2015, and it was sponsored by the National Heart, Lung and Blood Institute. And this trial was designed with 9,000 patients, and they were followed for 3.5 years. The study was initially decided to be followed for 5 years, but given the results and the significance between the two arms, they terminated the trial prematurely earlier. They included older patients, older than 50 years old, and in this study, the proportion of females was lower. And they included patients with a blood pressure higher than 130 without diabetes, no diabetes with history, with no diabetes and stroke with at least one of the risk factors of cardiovascular disease, non-cardiovascular disease, chronic kidney disease, or a Framingham risk score of more than 15% or older than 75 years old. And again, similar to the previous trial, to the core trial, the design was to randomize to intensive therapy to achieve a blood pressure of less than 120 versus a blood pressure goal less than 140. And all the major classes of antihypertensives were used. Another point that I forgot to mention in the core trial is that these patients were followed for 3.5 years. In fact, the design of the study was to follow, as I said, for 5 years. A core trial, they follow the patients only for 1 year. So that is another question if maybe the follow-up was just not enough to show a difference. And this is a very important trial to remember, because it showed that in adults with hypertension without diabetes, lowering the systolic blood pressure of less than 120 versus a higher goal of less than 140 showed significantly lower rates of cardiovascular events. It reduced the rates by 25% and death by 27%. Adverse effects, of course, as expected, were higher in the intensive control group. However, except for the falls and the progression to end-stage renal disease, there was increase in creatinine, there was more hypertension, more syncope, and electrolyte abnormalities, of course, but they didn't consider this as a major side effects. So, and then I couldn't finish talking about these relevant trials that have tailored and have guided to where we are now in hypertension without mentioning the invasive strategies, specifically renal denervation. So back in 1940s, based on the presumption that high blood pressure was attributed to the overreaction of the sympathetic system, surgical therapies were considered, and we're talking about sympathectomy and partial adrenalectomy at that time, so you can imagine. But later in 1960, when all these the pharmaceutical companies were researching all these medications with lower side effects, all these interventions fell interested, and at that point they stopped being used. However, as you know now, renal denervation is back on the table. It's another tool that we have now, and it's a novel and promising treatment of resistant hypertension. And what it is effectively partially ablating the renal nerves. This includes the afferent sensory fibers and the efferent sympathetic fibers that to the renal arteries. And they actually block the communication between the kidney and the paraventricular nucleus in the hypothalamus, and then the periphery with the periphery. That includes the heart, the kidney, and the arterioles. Because as we know, the efferent renal sympathetic nerves, they induce the renal secretion through the beta-1 receptor. They induce sodium reabsorption in the kidney, and they increase the renal vascular resistance. So this is a rationale to perform the renal denervation. There are 3 methods, and this is out of the scope of this talk, of course, but this is just a summary of there are 3 methods: the radiofrequency ablation, the ultrasound ablation, or the chemical ablation. None of them have shown to be significantly different. And the efficacy of renal denervation has been controversial. If you remember a few years ago, the Simplicity trial came out and there was no significant difference. However, more recent randomized sham-controlled trials have shown a significant blood pressure reduction in these patients. And that's why I'm not going to go over every single study. I just want to mention this meta-analysis that was published recently, in which they screened over 400 citations, and they finally included 9 good quality randomized sham-controlled trials that included a total of over 1,500 patients. And this is the meta-analysis results. They included patients that were in this range of blood pressure, this ambulatory blood pressure, and these patients would follow up to 6 months. So this is a table that I included, and this is all the studies that they included in the meta-analysis. And of those 1,500 patients, that, as I said, sham-controlled, good quality studies that after the screening, this is the arm that was randomized to renal denervation, and this is the arm that was randomized to a sham or control procedure. And as you can see, this is all statistically significant. There is a difference between renal denervation and sham procedure in the 24-hour blood pressure, in the daytime systolic blood pressure, nighttime on-office systolic blood pressure. So all these 9 studies show that it significantly reduces all these parameters. The only parameter in which there was no difference was nocturnal diastolic blood pressure. There was no evidence of harm associated with renal denervation, and there was no significant blood pressure reduction between the generation trials, the devices, or those patients that received were or not on antihypertensives. So in conclusion, we know that renal denervation significantly reduces office, home, and 24-hour blood pressure parameters in patients either with resistant hypertension, with uncontrolled hypertension, or drug naive. There was a sustained effect up to 3 years from the follow-ups that are now, and it definitely may provide a long-term additive to cardiovascular prevention, even when combined with pharmacotherapy. And one of the conclusions that we need to keep in mind from this meta-analysis is that ambulatory blood pressure monitor is the best way to assess blood pressure response. Also, I want to include here how there have been few studies showing the effects of renal denervation, not only in blood pressure, but in other conditions like atrial fibrillation and heart failure. This trial was published in JAMA in 2020, and it's called the Eradicate Atrial Fibrillation. And it was a single blind randomized clinical trial in which it was compared patients with atrial fibrillation, and here I included the table, patients with atrial fibrillation that underwent pulmonary vein isolation for arrhythmia control, compared to and they randomized them to receive the pulmonary vein, they underwent the pulmonary vein isolation and the renal denervation. As you can see, the freedom from AFib, flutter, and tachycardia was higher on the arm that underwent pulmonary vein isolation and renal denervation. Also, on heart failure, there have been studies in rats and preclinical studies that showed that renal denervation in HFrEF inhibits the renal neprilysin activity, which is the enzyme that degrades the natriuretic peptides, and the renal denervation actually increased the circulating levels of natriuretic peptides. They act similarly to the combination of that we use this combination in heart failure, the combination. They reduce the left ventricular fibrosis and improve vascular function and LV ejection fraction. We know that renal denervation through all these animal studies, they block the activation of renal angiotensin system, and they reduce the circulating levels of angiotensin 1 or 2. And unfortunately, after the negative results from the Simplicity Hypertension 3 study, there have not been studies to assess the renal denervation safety and efficacy on heart failure. On HFpEF, also, there have been studies, and there have been small retrospective analysis and observational studies. And here I listed two. For example, they were published in 2014 and 2018 in a randomized clinical trial of resistant hypertension. A quarter of those patients in which they performed the procedure had HFpEF. And it showed that those patients at 6 months had reduced left ventricular mass, they improved the systolic function, and the circumflation strain as a surrogate for diastolic function. And also in a multi-center cardiac MRI study, 16 patients with resistant hypertension that underwent renal denervation showed that there was a reduction of LV mass and improvement on diastolic function. So what is the future of renal denervation? And it's interesting, and I think it's a field that has plenty to still show us, and there is still going on trials that will be finalized and published hopefully in this year and in 2024. For example, there is on the table this study of the electrical mapping of the renal arteries to optimize the effect and identify who is going to be a responder to renal denervation, because of course there is variation of some patients that respond very well, and others that don't. And in fact, what I think is interesting is that, for example, they've seen that the patients with a higher plasmin renin activity, actually they have an increased greater control of systolic blood pressure when they undergo the procedure. And also those patients that had a baseline office heart rate more than 70 beats per minute, they actually respond better to the renal denervation measure after 3 months. We still have questions about the long-term effects, the effects on reducing the number of drugs and dosages, because we want to see that, and the patients want to see that, of course, and the long terms of cardiovascular outcomes, of course. So then we can go to where we're going to talk about the hypertension guidelines. I'm kind of finished with this story because I want to talk to you briefly about how has the guidelines of hypertension evolved along the time. So in 1972, after the publication of the Framingham Heart Study and this VA study group trial that I mentioned to you, the National Heart and Lung and Blood Institute appointed a committee of representatives that included multiple major medical organizations to generate guidelines of treatment of hypertension. And it was in 1977 that the JNC report, the first one, was published. And it's interesting, and I mentioned before, the targets were different, were significantly different to what we use now, and were higher. At that time, blood pressure was treated, the target or the threshold was determined by the diastolic blood pressure, more higher than 105 millimeters of mercury. And of course, diuretics were first line, and it was reserpine, methyl-dopa, propranolol were in the guidelines. And every 4 years, approximately, the group used to reconvene and generate new guidelines, updated guidelines as more trials came up. And the initial guidelines, as I mentioned, were very conservative. For example, then the following reports came up with a threshold of more than 160 over 95, which is extremely high, only on those patients younger than 50 years old. Those patients that were older than 50 years old, you had to wait until blood pressure reached over 200 over 110. So as you can see, this is way different of what we do now, and they were very, very conservative. And then in the 1980s, other studies other updates were published, and it was systolic blood pressure was included at that time, and the threshold came down, and it was when beta blockers were added. However, guanethidine and minoxidine was in the guidelines. Then in 1988, the JNC4 report came up, and calcium channel blockers and ACE inhibitors were added to the list, to the diuretics and the beta blockers. Although there was no data on long-term benefits. And in 1993, the JNC5 was published, and it was a more structured and detailed report on how there was the first time recommendations for prevention of high blood pressure and non-pharmacological therapies were included in the report. And the first time that this threshold was included of 140 over 90. And they mentioned, consider further reductions at that time, only until 1993. And at that time, we already have data about elderly, reducing stroke in morbidity and mortality on the elderly. And diuretics and beta blockers were the preferred therapy at that time, being calcium channel blockers and ACE inhibitors second line. Then in 1997, the JNC6 combined lifestyle modifications for the first time, and they include the high normal. That's when the high normal blood pressure, the 130 to 139 and 80 to 89 millimeters of mercury was included. And they started to recommend lower targets in patients with diabetes and chronic kidney disease. And then in 2003, which, as you remember, is the last JNC report, emphasized the importance of systolic blood pressure in older adults. And that's when the first time that 2 or more antihypertensives were the concept of using combination of drug classes was introduced to achieve a better blood pressure control. However, thiazides were still first line at that time. And then in 2013, that's when the controversy comes. In 2013, after many years of not having another report, the JNC8 was to be published, and indeed was published. However, it was very, very controversial because the targets at that point were actually increased to more than 150 over 90. And in fact, 5 members of that committee actually published another document criticizing those guidelines. So at that point, the National Heart, Lung, and Blood Institute transferred the responsibility to the American College of Cardiology and to the American Heart Association. And in 2014, later, the AHA and the ACC and other 9 partner professional societies appointed finally a writing committee to develop a more comprehensive clinical practice guidelines. And that was when the guidelines that we're currently applying were published. And if you see, it was a more comprehensive document. It was titled The Guideline for Prevention, Detection, Evaluation, and Management of High Blood Pressure in Adults. And that's what we're going to talk about And those are the guidelines we're going by at this point. So here is the screenshot of the guidelines. As you see, it's 9 associations involved here. And the relevant points that I want you to take home out of these guidelines is how the importance, and this is the first time that they dedicate a huge part of the guidelines, and that's why the guidelines are so extensive, about the importance of the accurate blood pressure measurements. Also, there is a new classification system defining hypertension with a systolic blood pressure more than 130 over or a diastolic blood pressure more than 80, so the threshold came down. And they recommended the quantification of the cardiovascular risk of our tool, that with the equation for the guidelines of treatment decisions. For example, those patients, all adults, should be treated for high blood pressure when the blood pressure is more than 140 over 90. However, in those patients with a 10-year risk of higher than 10% should be treated with when the blood pressure goes higher than 130 over 80. And the general, the goal should be under 130 over 80. So this is the first time that these guidelines are more strict in their targets. Also, there is a focus on the functionality and recommendation of similar blood pressure goals in older adults compared to younger adults. So for the first time, these older adults are recommended to have similar systolic blood pressure goals, but of course, taking into account their functional level. So they should be applied to non-institutionalized community dwelling patients who can tolerate their treatment. And these guidelines, as you can imagine, after having the JNCA report being published with a blood pressure threshold of more than 150 over 90, and here come the other guidelines, a more comprehensive document with different societies involved, with a goal of more than 130, there was a lot of controversy. However, major English language clinical practice guidelines agree in general, they along with the 2017 recommendations. For example, and I don't mean to go over to compare with the different guidelines, but if we compare to the European Society of Cardiology and Hypertension guidelines published in 2018, they use a different classification, but they lowered the thresholds of initiation of therapy and lower targets for blood pressure than prior studies. And they also focus on the functionality of the individual, of the patient, rather than a chronological age. And then this is just a summary. I'm gonna talk to you about the important points of this guideline, because as I said, it's a very extensive document. But this is the guideline. This is where they review and they give recommendations to practitioners. And as I said, they don't only talk about treatment of blood pressure, but they include non-pharmacological interventions, the comorbidities, the special situations, the strategies, given that we see the increase on blood pressure uncontrolled in the United States, in our country. So first, I'm gonna just include few highlight points from each of the section. So in terms of cardiovascular risk, we know that there is a log linear fashion when the blood pressure is above 115, and with the diastolic blood pressure is lower than 75. And higher levels of both diastolic and systolic blood pressure is associated to cardiovascular disease, increased cardiovascular disease risk. It's not only the systolic blood pressure. And 25% of the cardiovascular events at this point can be attributed to hypertension. This number is higher in women, 32%, than in men, and higher in Blacks than whites. This is a new classification for blood pressure. Elevated blood pressure now is considered 120 over 129, and this is very important because this is when counseling and preventive strategies need to be applied. And a normal blood pressure is considered less than 120, not less than 140 as it used to be before. And a stage 1 hypertension is 130 to 139, or diastolic blood pressure 80 to 89. And a stage 2, those patients with blood pressure of more than 140 are already considered a stage 2. And there are no other stages like the previous document, there used to be a stage 3. They talk a lot and they go into detail about the measurement of blood pressure, the proper technique. And again, this actually goes along with recent studies that show the ambulatory blood pressure monitor is the best way to evaluate blood pressure response. However, the home blood pressure measurements are more practical, of course, and we should include this in our practice. And they talk about the patient training, the devices, how multiple reads should be taken, and they go into details of how to do it, actually. And it's a guideline, it's a guide for the clinicians, and there was no consensus about it. And this is just to show you how, if you want to ever look into what is the proper cost for your patient, they actually go into these details, which is the first time it is included in one of these documents. And there is equivalence of blood pressures when you compare the home blood pressures with ambulatory blood pressure and the 24-hour blood pressure monitors. They talk about the causes of hypertension, how there are genetic causes, environmental factors, drugs, just to remind you that there are drugs like amphetamines and that are frequently used in our population. At least I see several patients for ADHD, adults, amphetamines, antidepressants, antipsychotics, decongestants, and other supplements. They actually include the supplements that are associated to hypertension. That's St. John's Wort, Mahun, and other medications, of course, that we commonly use. In fact, the specific reversible cost can be, they say that only up to 10%, but actually find this a significant number if we can identify what the causes is. And of course, if we can work with this patient's condition to try to limit the use of these medications. They go into details about the specific the causes of secondary forms of hypertension, giving us a guide of how we need to consider all these conditions in our patients: renovascular disease, obstructive sleep apnea, aldosteronism, and they are more uncommon. And we know that there are less than 2% conditions like pheochromocytoma, Cushing's syndrome, hypothyroidism, aortic hypertension, acromegaly, congenital adrenal hyperplasia. And they give us a recommendation of when to screen for secondary hypertension. And the non-pharmacological interventions. For the first time, there is a good chapter on which non-pharmacological interventions have been studied and which ones show to be effective in reducing blood pressure. As you can see here, there is actually a calculation of the milliliters of mercury that you can reduce by adopting lifestyle measurements. DASH diet actually is one of the more relevant, and of course, aerobic exercise. And what is the patient evaluation objectives? So it's a pretty detailed document in which that guides all the practitioners, the healthcare workers, how to start the evaluation and which interventions, what we need to discuss with our patients in the office. The pharmacological treatment, as I mentioned, in those patients that are lower risk, that don't have established coronary artery disease or cardiovascular disease, and they have a score less than 10%, to start treating when blood pressure is more than 130/90. For those patients with that need secondary prevention, or when the score is then more than 10%, we need to start treating high blood pressure when it gets higher than 130/80. This is the calculator for those of you who haven't seen it, but I'm sure everybody needs to be using this. And this is an algorithm. This actually, you cannot see it very well, but this is an algorithm of what I already discussed about the targets of high blood pressure according to their risk. So here, as you see, if there is no clinical, no cardiovascular disease, more than 140, and for secondary, and I think this is important, that's why I included this table here. For secondary stroke prevention, the goal should be less than 130/80. But when there is just only a stroke and no other conditions, we should treat those patients more than 140/90. However, as you can imagine, this is a very reduced population because most of our patients that have had a stroke, they already have other conditions. So where is the rationale for tighter blood pressure control? Because there was a lot of controversy, as I mentioned before. These guidelines are not being implemented as they should. And I don't want to go again over these studies because of time constraints, but we talk about the SPRINT study that was stopped early because it was a significant reduction in primary outcome on those patients with a tighter blood pressure control. In the ACCORD trial, it was not. However, the incidence of stroke was significant, and the follow-up was shorter. And there is a criticism about that study. And that's what they don't consider, what many groups don't consider, that we can go by the ACCORD results in that sense. And they actually, the SP3 study also failed to demonstrate a benefit from the primary endpoint. However, again, there was a significant difference in the subgroup with hemorrhagic stroke. In terms of pharmacological agents, it's important to remember that most patients need 2 agents, that the first agents are the thiazides. The first line agents should be thiazides, also always should be included if possible in the regimen, ACE inhibitors and ARBs, and calcium channel blockers. Agents with similar mechanism of action should be avoided. And again, this is a summary of the guidelines because it's a very detailed document about each of the agents. But thiazides and loop diuretics can be used, either one of them, with the potassium sparing diuretic, and the hydropyridine and the non-hydropyridine calcium channel blockers can actually be combined. In patients with comorbidities, and there is a section dedicated to each of these conditions. Those patients with ischemic heart disease, beta blockers, ACE inhibitors, and ARBs should be included. And then in patients with heart failure, of course, avoiding non-hydropyridine calcium channel blockers, especially in those with reduced heart failure. Diuretics should be used when volume overloaded. And as we know, the ARBs, the ACE inhibitors, and the beta blockers are first line. On patients with albuminuria, ACE inhibitors should be on the list. In kidney transplant, the goal should be less than 130/80. And something to remember, those patients with kidney transplant have shown to have lower rates of rejection and normal renal function with calcium channel blockers. In intracranial hemorrhage patients, we should avoid a blood pressure less than 140, a drop. And in acute ischemic stroke, the blood pressure should be less than 185 if we're using thrombolytics. In diabetes, as I mentioned, the ACE inhibitor ARBs, if there is proteinuria. In AFib, there is limited data, and the class is 2A recommendation that ARBs might be useful in preventing recurrences. In aortic stenosis, be aware to start a low dose to avoid hypertension. In aortic insufficiency, avoid bradycardia. And in thoracic aortic disease, beta blockers are recommended. In terms of special situations, thiazides and calcium channel blockers are more effective in Blacks and African Americans. And African Americans have a higher risk of ACE inhibitor-induced angioedema, and Asian Americans have a higher risk of ACE inhibitor-induced cough. In terms of sex consideration, women are more susceptible to side effects like edema or cough. Cough-induced, ACE inhibitor-induced cough, and edema with calcium channel blockers, as well as hypokalemia with diuretics. And in pregnancy, agents like methyldopa, nifedipine, or labetalol can be used. The guidelines specifically mention about how pregnancy is out of the scope of the guidelines, and they defer to the ACOG Association for recommendations, but they have a few lines on pregnancy. And then hypertensive crisis, when the drop of blood pressure should be achieved within an hour, or eclampsia or preeclampsia, aortic dissection, pheochromocytoma crisis, acute pulmonary edema, of course, acute coronary syndrome, and AKI, acute kidney injury, and they actually give a list of the recommended agents in each condition. As I mentioned, the pregnancy and high blood pressure, I just want to leave you with this message. Hypertensive disorders of pregnancy are increased risk factors for future cardiovascular disease. And as I mentioned, the nifedipine, methyldopa, or hydralazine are the agents we recommended, also labetalol. However, no agent has shown to be better over the other, except when clinical practice and experience come to play, and they defer us to the ACOG guidelines. In terms of resistant hypertension, diuretics should be included in those patients with uncontrolled hypertension, and we should be able to assess the pseudo resistance. And there is actually a list of conditions that we need to check, that they recommend that we check and we go over when we're facing resistance in the office. And they actually comment on the concern about cognitive decline and dementia, because one of the barriers is the patients and from the physicians is concerns about cognitive decline with treatment of hypertension, when there is evidence that the blood pressure lowering reduce the risk of Alzheimer's disease. Also, keep in mind that beta blockers are mineralocorticoid receptor antagonists, might have negative effects on libido and erectile dysfunction. And there is actually recommendations about how to manage blood pressure in the periodic period in which beta blockers should not be stopped or initiated close to the surgery. And ACE inhibitors ARBs can be considered to be discontinued prior to the surgery. So what are the strategies to improve high blood pressure control? And this is a field that is that several associations are working on because of what I mentioned before, the drop in the rates of blood pressure control and awareness. Single pill combinations are known to improve adherence, lower blood pressure and cardiovascular and death rates. Self blood pressure, self measurements of blood pressure engage the patients and have shown to speed the control of blood pressure. We should include our patients, engage them into blood pressure monitoring at home. A team-based care approach, including maybe pharmacists, use their Emory for a screen and to screen and to follow up patients. And there are strategies and there are associations working in maybe accessing Wi-Fi points for the patients to communicate with their providers. And now after COVID, the telehealth visits and strategies that were developed can actually use them to eliminate or to use the barriers like transportation difficulties, childcare, and taking time off work. This is something that we could implement to control blood pressure. And financial incentives to providers and healthcare systems, not to incentivize by number of patients, but by targets of blood pressure control, for example, and expand the insurance coverage. And there, as I mentioned before, Medicaid expansion has shown to improve blood pressure control in terms of, for example, coverage for devices, reducing copayments of medications, and aiding with transportation challenges. So, in conclusion, uncontrolled hypertension leads to a largely preventable death, and the improve in blood pressure control can have impacts in a short period of time. And the new guidelines propose a lower blood pressure thresholds and goals for long-term treatment of hypertension. And there are national strategies to reduce the health and economic burden of uncontrolled hypertension. And just to remind you, in African Americans, fast-side diuretics and calcium channel blockers are more effective. And fast-side diuretics, calcium channel blockers, ACE and ARBs are all first line, and they are all are known to reduce cardiovascular events and reduce renal outcomes. And of course, ambulatory blood pressure and home blood pressure measurements, as I mentioned, provide an enhanced ability to both diagnose and control and monitor hypertension treatment. Thank you very much. I'm happy to answer any questions.
Thank you so much, Dr. Gongora. That was outstanding. And really thank you for that review and also the history, which was very interesting. We have about 5 minutes for questions. So while I'm waiting for people to type in their questions in the chat, I'll start off with a couple. One, what are the thoughts about wearables, wrist blood pressure monitor versus arm? Is there one that's preferred, or what do people think?
Yeah, actually, it's interesting. Here at Midtown, we have a list of blood pressure monitors that we recommend. And yeah, I always tell the patient, not the wrist ones. They should be the arm blood pressure monitors, the ones that are recommended. And as I said, they should take into consideration the size of their arm. There is in the document, there is specific about which number of millimeters of mercury can be affected by the cuff. So yes, not to the wrist monitors, and yes to the arm adjusted for size.
Great. Okay. And then for diastolic blood pressure, often I'll see younger women under the age of 40 or so. They have some mild elevations in diastolic pressure, but the systolic is absolutely fine. Is there a particular class of drugs that you reach for diastolic hypertension?
No, and I have that problem all the time. And you're right, the blood pressure is 125 and the diastolic is over 90. And no, I mean, there's no specific blood. I mean, it's just, I particularly try to avoid the beta blockers, of course, because of side effects, but no, there is no specific agent known to target more diastolic than systolic blood pressure now.
Okay, great. Anybody else have any questions or?
Carolina, Steve Clements.
Yes.
Hey,
hello.
So do you recommend, and do we, and should we, and how should we calibrate our blood pressure cuffs that are on the wall? How do you react to that?
Yes, I think, actually, I hadn't thought about the walls on the wall, but you're totally right. I use it all the time for the blood pressure monitors from the patients at home. So what I tell them to do is to bring their blood pressure, monitors to the office, and we calibrate them so we can compare the ones that we are. But that's a great question, Dr. I hadn't thought about it. I don't know about some of the wall ones, the ones in our offices. I don't know how often they are checked, or I don't know. I usually use those for my manual blood pressure to double check, for a recheck when I see a high blood pressure, but I'm not sure if those are calibrated. That's an excellent question. I'm not sure.
Well, my thoughts are that we probably don't do it, although I've asked about it and said that it was done. We probably do need to do it. And notoriously, when we have that automatic blood pressure cuff reading and it's high, then I grab the one on the wall to do again. And I'm wondering whether or not that one's correct. There are ways you can do that. And the last time I asked about it, it said it was done once a year, but I don't believe it. But I think we probably, throughout our institution, ought to regroup and try to find some way to calibrate our blood pressure cuffs on the wall. And it's always a good idea, as you mentioned, to ask the patient to bring their blood pressure cuff in so you can at least calibrate whatever you have with that.
Yes.
Great call, Carolina.
Thank you. Thank you, Dr. Clemens.
Great. So Carolina, if somebody has a blood pressure of 123/80, and then another one, 126/80, are you coding that as elevated blood pressure because you don't want to give them a diagnosis of hypertension?
Yes, I think because technically you should. And in fact, I read the 24-hour pressure here, the monitors. And yes, you have to be, that's the official classification. You have to tell them you have elevated blood pressure. And it takes, that's the problem that, was calculated that for us to control blood pressure, we would need like several hours for education. But yes, that's elevated blood pressure. You need to educate the patient, and that needs to go into the chart as a diagnosis. Of course, you have to take into consideration measuring, and maybe you're not going to code it right away the first day they came to you. But if they persistently have a blood pressure above 120, yes, it is elevated.
Yeah. So, coding for elevated blood pressure is different than hypertension code, like, ICD diagnosis.
Yes, and if you see the code is there. There is a code that is elevated, yes.
Right. Okay, great. If there are no other questions, we are right at 8:30. You did a great job of going through all those slides and staying on time. Don't forget to get your CME. I'll see you next week.
The preceding program is copyrighted by Emory University.